Hello everyone and welcome to this webinar on early intervention for borderline personality disorder. My name's Stephen Carbone. I'm the Executive Director of Prevention United, and we're really thrilled today to be partnering with the Australian Borderline Personality Disorder Foundation and Orygen on this fantastic webinar. So to begin, I'd just like to acknowledge the traditional owners of all the various lands that we're meeting on today. In my case, it's the Wurundjeri people of the Kulin Nation here in the northern suburbs of Melbourne. And I'd like to pay my respects to their elders, past, present, and emerging. So today's webinar will run for about an hour and a half. We're going to kick off with some presentations from each of our guests, and then we're going to have a very brief panel discussion where I'll be posing some questions to the panel members, and then we're throwing it over to you, the audience members, to be able to ask your questions of each of our guest speakers. In terms of some basic housekeeping, I'm sure most of you by now are extremely familiar with the Zoom platform, but with Zoom webinar, there's a few features. The chat function here, I wonder if we could use that if you're having any technical difficulties. So one of my colleagues, Lachlan Kent, will be able to answer any tech issues that you're having if you jot any comments on chat. And then later, when we come to the audience Q&A section, you can pose your questions here in the Q&A section as well. Obviously, we'll be talking about some fairly sensitive issues, and you know, if this causes any distress or you feel you require some personal mental health support, we definitely encourage you to contact either your GP, your current mental health worker or peer support worker, but also to please ring one of the many helplines that's available: Beyond Blue, Lifeline, Kids Helpline, or jump on to the headtohealth.gov.au website for more information. So to begin, we thought we might just kick off with a few poll questions just to get a sense of our audience and who's out there, so that everyone's familiar with the audience. So I'm just going to bring up the first poll question, and hopefully everyone can see those. So the first question is, what is your primary role here today? And the options are person with lived experience, clinician or practitioner, family member, friend or carer, researcher, policy or advocacy position, or other. So I'll just wait for those. Then the second one is, what age group are you in? And the last question is, if you are a family member, friend or carer, what age is the person you support? So I'll just give people a bit more time. I can see that about a third have, and look, there might not be all the options there that we have covered, so apologies for anyone who's here that doesn't neatly fit into one of those categories. So we'll give it a bit more. And apologies, I can see some people are saying it won't let you submit. I'm not quite sure what's happening there. I'll ask my colleague Lachlan to see if we can sort that out. Okay, we've got about 3/4 of people have voted now. So in terms of the majority, there's about 10% of people with lived experience, about over half clinician or practitioner, 54%, another 26% family member, friend or carer, and about 5% who are researchers, 5% other. There's about 5% of people under 26, that's great, and then probably evenly spread, about a quarter, 26-35, 12%, 36-45, and around similar numbers for the other age groups. And if you're a friend a family member, friend or carer, what age is the person you support? The vast majority are under 26, 62%, and then 25%, 26 to 45, and another 9%, 46 to 65, and 6% over 66. So that's it there, I guess, if you can see the results in front of you. So as I said, most people clinician or practitioner, most people in that 46 to 55 age group, and most people who are family members, friends or carers are supporting someone under the age of 26. So that's fantastic. Okay, so without further ado, I might now like to introduce the first of our speakers. It's Rita Brown. So Rita is the president of the Australian Borderline Personality Disorders Foundation, which for a number of years has collated an awareness campaign for BPD Awareness Week, which is this week and why we're having this webinar. She has lived experience of supporting caring for someone with BPD and is the carer consultant at Spectrum Personality Disorder Service. She utilised her experience to advocate for people with BPD and their family and friends, and the inclusion of lived experience voice in service development and provision within Spectrum, and more broadly at state and national levels. So Rita, welcome. I might ask you to switch on your camera and unmute, and I'll throw over to you.
Thanks, Stephen. I'll also share my screen. So I'd just like to welcome you all here today and acknowledge the traditional owners on the lands on which we're meeting and pay my respect to their elders past, present and future. As Stephen said, I'm the president of the Australian BPD Foundation, and just a really quick introduction to the foundation. We're a group of volunteer consumers, carers and clinicians who are passionate in encouraging a positive culture around BPD and promoting the ready availability and accessibility of appropriate services for everyone impacted by BPD. As Stephen said, as part of our activity, we host an annual conference, usually held live around Australia, and also coordinate a group of interested organisations and individuals to organise a BPD awareness campaign each year. This year would have been our 10th conference, and like so many parts of our lives, we've had to adjust to current circumstances. So a conference and awareness week have morphed into a week with 14 events, mostly online. This year's campaign, titled Flipping the Script, Changing the Narrative on BPD, aims to change the way we think and talk about borderline personality disorder. And I'd like here to acknowledge the tremendous work done by a graphic designer, lived experience advocate from New South Wales, Marley Jewell. She's taken the lead in designing the website and all the resources. So the campaign encourages people living with BPD to be mindful of the way they think about themselves, allow others to see their challenges, move towards strengths-based self-talk, and to celebrate their strengths. And on this page here, which is part of the Awareness Week website, there's a number of stories from people with lived experience and those who support or care for them. There's also a page of Art Against Stigma, which is encouraging people to contribute some artwork based on the theme of flipping the script. The campaign also challenges families and supporters and those working with BPD to change the way they speak and write about people living with BPD, to encourage and promote individual strengths, reframe their challenges into strengths-based language, educate themselves by accessing new research, and amplify the voice of lived experience. So we have this lived experience website where we make available all of our resources, and you can see there's some of the posters that Marley's developed. These are all available for free download. We ask that you do not edit and acknowledge the source, and just once again acknowledge Marley's work in all that she's done. And that's it for me. So I'll hand back to you, Stephen. Thank you.
Thank you very much, Rita, and thanks for all the fantastic work that the Foundation's doing, and particularly during this particular week. So thanks for that. It's now my great pleasure to introduce our first speaker, and it's Professor Andrew Chanen. So Professor Chanen is the Director of Clinical Programs and Services and Head of Personality Disorder Research at Orygen in Melbourne. He's a Professorial Fellow at the Centre for Youth Mental Health at the University of Melbourne. Andrew's clinical research and knowledge translation interests lie in prevention and early intervention for severe mental disorders, principally personality disorder, along with mood and psychotic disorder. He established and directs the Helping Young People Early, HYPE, Prevention Early Intervention Program for severe personality disorder in young people. HYPE has been recognised with several awards for advancing healthcare. And Andrew himself is a prolific researcher and has over 140 scientific publications. He serves on several editorial boards, and he's also on a number of expert mental health groups and committees. And he's the past president of the International Society for the Study of Personality Disorders. So it's my great pleasure to throw over to Andrew for his presentation. Thanks a lot, Andrew.
Thank you. And thank you very much to Steve and Lachlan and the whole Prevention United team for inviting me to be part of this and for organising this today. It's a real thrill to be able to have this kind of webinar and to be able to present nationally on these sorts of issues. I'd also like to acknowledge the traditional owners of the lands on which we meet and to acknowledge their elders, past, present and emerging. I'm hoping that you can see the slides.
Yes, all good, Andrew, all good.
Okay, all right. So what I wanted to talk about is about why we should be intervening early, and then one way of how we might go about doing this. Just to let you know, I don't have any conflicts of interest to declare, but I have lots of people to thank. I won't dwell on this, but just to say that I'm standing on the shoulders of many, many people, and you can see how happy they are. That's long ago, in a time when we could all get together and be near one another. But I'm supported by a fantastic team who have made a tremendous contribution to this work. So one of the challenges that we really took up and that I think the system has to still address is that the normal kind of approach to personality disorder in the mental health system is late intervention. We wait for a very long time to make a diagnosis, to let people into the system. We only offer highly specialised treatments very late in the course of the disorder. Usually they're begrudgingly offered, usually to only a very small number of the people who actually need them, and usually only to those who are help seeking, not to everybody. So you have to jump through lots of hoops and be well behaved and accept the constraints of the health system in order to get care. And calling it a health system for personality disorder is probably a bit generous, because there really is no coordination of the service system. It's a patchwork of a few services, a lottery really as to what services you get. And sadly, we tend to intervene usually when people have already experienced long periods of disability. There's a very strong focus and a very strong belief that the only form of treatment is individual psychotherapy. And sadly, many people have very adverse experiences of the health system, and some are harmed by the health system. So hopefully that outlines why you might think we would intervene early, but if that wasn't enough, one of the important points to make is that really the name borderline, and it's had a long but controversial history, is really just a synonym for severe personality disorder. And it describes a group of people who have a very high risk of poor outcome in life and who have currently, at any time, significant problems. So our aim in early intervention is not narrowly focused on just the features of borderline personality disorder, but actually on the fact that this is like a red flag for a group of people that you can identify early in life who are at risk of having great difficulties across their lifespan. It also demarcates a group of families, friends, other caregivers who experience very high levels of burden. There's a piece of work that Sue Cotton, one of my long-term collaborators, is just finishing, where in fact we've shown that the families of young people with BPD experience greater levels of burden and higher levels of expressed emotion than do caregivers of young people with first episode psychosis. Yet we never contest the idea that the families of young people with first episode psychosis should have a foothold in the mental health system. However, for families and friends of young people with BPD, they're often marginalised or even demonised in the system. We also know from a very long and very productive series of studies, but dating back many years, that borderline personality disorder or severe personality disorder in young people is not part of normal development, that it's associated with a very high burden of mental health problems, including self-harm. And it's really one of the key things that I want to impress here is that it's associated with severe and persistent functional disability. That is, disability in regard to relationships, but also vocational disability. And this is a group way overrepresented in unemployment statistics. And importantly, particularly in a recession like we're experiencing now, a group who are likely to be left at high risk of being left behind in the vocational opportunities that might be available trying to come out of recession. This is a group who are also at very high risk of poor physical, sexual and reproductive health as well. And I think this is the most tragic statistic of all, that patients, and I use that word specifically because this study was done on people who are actually service users within the mental health system with personality disorder, live 2 decades than their peers in the community, 2 decades less than their peers in the community. That is an indictment of the way that we approach this problem. So who are we actually trying to target here? There's a real, a very clear consensus internationally that BPD can be diagnosed from around puberty and that it is a reliable and valid diagnosis. And that really hasn't been contested for a very long time. But there still is a focus internationally on so-called adolescent personality disorder. And the field has really ignored the developmental continuity of that period of life from puberty through till about the mid-20s, which is a particular period of vulnerability and coincides with the clinical onset of most of the major mental health problems. And so we really can't deal with prevention or early intervention of personality disorder without thinking about the whole range of mental health problems that often co-occur with people with personality disorder, but also get mixed up in the whole kind of presentation. You know, many of you will be aware of misdiagnoses and changed diagnoses as time goes on, that we really need to think of early intervention for BPD as a core part of youth mental health. This is one of the most common problems in youth mental health, yet it's still marginalised in all parts of the system. And we also know that young people with BPD, whether they be under 18 or over 18, share much more in common than they do any differences. We've just submitted a paper showing substantial similarities on 20 key aspects of their presentation. And showing, though, that there are meaningful differences within this, you know, in terms of household makeup or treatment history or the level of antisocial behaviour. These sorts of things are important in terms of planning services, but they're not the main point here is that this is a group who have much more in common than they have differences. We know that in the younger group, they're more likely to be living with their family. That's partly because it's, you know, normal at that age, but also they're likely to have higher levels of self-harm. The older group are likely to have dropped out of education and not be achieving the vocational milestones that people would in the transition to adulthood, or in the transition from school to the workforce or tertiary study. And what's the threshold for intervention? You know, we often get very caught up about when should we be assessing somebody as eligible for a program. In fact, what we know is that any of the features of BPD are associated with poor quality of life, associated with symptoms and distress, high levels of mental health service usage, poorer functioning, and really the arbitrary kind of threshold that we have for diagnosis doesn't actually inform us very well about early intervention. We really should be targeting efforts toward people with any of the features of BPD, particularly because by the time somebody is defined as a so-called case or, you know, reaching a threshold, much of the developmental disruption and damage to future prospects has already occurred. And then we're really trying to unscramble an egg rather than prevent the egg breaking in the first place. We also know that the features of BPD naturally get better, and I've got that in inverted commas, over time, but the diagnostic features actually attenuate over time. What doesn't change, though, is the impairments in social and vocational functioning. And these persist for decades after the diagnostic features have gone. And just, you know, for example, compared with any other psychiatric disorder, this is a Danish study showing that people presenting for their first time with BPD have a 1/3 lower chance of being in work or education 9 years later. So this is really devastating for the transition to adulthood. And we know that the interpersonal and vocational outcomes are often overshadowed by this focus on BPD features like emotion dysregulation or self-harm. And I'm not saying that we shouldn't focus on them, but I think we focus on them to the exclusion of what is the ball in the game, which is these persistent impairments that people experience. They're like a kind of a shadow of the disorder that persists. So the principles of early intervention, we think, are that you should include as many people as possible, and you should minimise the number of people that you can't see. Often programs expect all sorts of things of people to be eligible, that they can't be using substances, that they can't have antisocial behaviour, that they have to have a certain intellectual capacity. We really need to try and minimise the reasons for excluding people from treatment. We need to look at BPD on a spectrum of severity so that we include everybody. We need to assess people carefully to determine the range of problems that they have. And all the successful programs have been time limited. We need to kind of do away with the expectation that early intervention is about inviting people into the health system earlier just to keep them there for a very long period of time. Successful early intervention should mean that you actually exit the mental health system and get on with your life, only to access the system when you need it. And importantly, there's a lot more to early intervention than just psychotherapy. Everybody who seeks care should receive some sort of care. We call the broad care package that we offer relational clinical care, but you can see that individual therapy is just a component of an overall treatment package. And people often ask, well, you know, is early intervention effective? And unequivocally, yes. There are now 8 high-quality clinical trials that show that people with either features of BPD or the full disorder improve with treatment. But what they show is that a range of structured treatments that is designed for young people with BPD are effective, not that one treatment is more effective than another. And whatever the evidence says, it's incredibly rare to find these treatments available in healthcare systems internationally. And we also need to be thinking about what are the specific components of treatment that might be important. We know that these overall packages work, but we haven't really broken them down into the kind of elements that that we think might be effective in order to be able to think about what are the really important ingredients of treatment. So one of the questions that we asked was, could a less complex intervention be developed that's scalable across health systems? Because this is a very prevalent problem. This is a problem that occurs at the diagnostic level at about 3% in young people. But when you consider people across the spectrum of severity, it's up to half of people presenting to youth mental health services who have these sorts of difficulties. So we conducted a trial. It's called the MOBI trial. You can find the protocol published. We're just finishing the actual paper for submission. I'm not going to go through it in detail, except to say that what we asked is, what's the comparative effectiveness of different levels of complexity of early intervention for BPD, and is specialised early intervention more effective than general youth mental health care, and what's the contribution of individual psychotherapy over and above these kind of service models. And then we also wanted to combine the under 18 and over 18 groups to see whether early intervention is effective for emerging adults as well as for those who are in their teenage years. You don't need to fuss too much about the details of the graph, except to say that what this shows is that everybody improved regardless of the group. There were some trivial differences, which I won't dwell on, in terms of outcomes very early on. Essentially, everybody got to the same place in the end. And although it might not look so on these graphs, but the level of improvement was substantial. And that's in terms of interpersonal problems, and this is in terms of social adjustment. So people did well, and that's the good news message from this. There was, as I said, a marked and sustained improvement, and individual therapy didn't really confer any additional benefit over and above high quality care in relation to outcome, and a highly specialised model was not superior to a high quality youth mental health model that was designed to be open and accepting of young people with personality disorder. However, the important difference between the groups was that the specialised service did retain people in care more than the generalised service. And I think that, I won't elaborate too much on that, but we do think that's an important distinction. So how does this translate into actually what we do? Well, in the HYPE program, our central focus is on young people, families and friends. We want active collaboration and participation. We want to tailor the program around the young person's goals, rather than saying, you can have any treatment you like as long as you stop self-harming, or as long as we're focusing on your self-harm. If that's what they want to work on, we do. Obviously, we're not reckless. We make sure safety is at front and centre of what we do, but we have very flexible goals that are focused on the young person's goals. We include families and friends, and we make sure that wherever possible, they're a part of the treatment. And obviously when there is a conflict, or when it's inappropriate, we are mindful of the young person's wishes, but we're always aiming to not just accept that at face value and talk to both the young person and the family about any familial difficulties. And you saw when I presented at the start that family burden is a huge problem in this, even in this age group. And that families are often exhausted by the time they get to us. And our aims here are to improve functioning. You see, none of those aims actually say to reduce BPD. Actually, what we want to do is improve functioning, reduce mental health problems and distress, but we want to also promote adaptive help seeking. This is a group who will need mental health care in the future, but early on learn through their adverse experiences in the system that care is difficult to get, and learn kind of maladaptive ways of seeking help. And we want to also enhance their ability to look after themselves. And we want to put the young people and families and friends at the centre of this model. So the HYPE approach is relational, integrative, reflective, and collaborative. It has a kind of an acute phase when there's a lot of turmoil, which involves assessment and coming to a shared understanding with the young person. Then there's a kind of a working phase, and you can see this is not a long treatment program. On average, people spend about 200 days in the program, which is, you know, just over 6 months, and then they move on. We have a relational model at the core of what we do. It's based on a treatment called cognitive analytic therapy, and it's used in all aspects of treatment. So it's one of the initial tasks is to come to a shared understanding about the person's story and the challenges that they face. And then there are essentially 3 key elements. There's clinical case management, individual therapy if it's needed, and psychiatric and general medical care. And the clinical case management is integrated with the individual psychotherapy so that there's not this demarcation, and also that there are opportunities to generalise the learnings of individual therapy if that's part of the treatment package. So for those who engage early on, we still do offer individual psychotherapy if they want that. But I guess the point we're trying to make here is that you can do high quality care without necessarily having to engage in individual therapy. There's a whole team approach, and there is team input into everybody's care. And the medical component of that care also involves a focus on physical health and on making sure that prescribing is rational. So to conclude, BPD usually has its so-called onset between puberty and young adulthood. There's a very high potential for BPD to disrupt the successful transition to adulthood with lifelong consequences for interpersonal and vocational outcomes and for physical health. And there's strong evidence to support early detection and intervention, and integration is needed with similar endeavours for depression, psychosis, eating disorders, across the whole range of problems in the mental health system. And importantly, clinical care is likely to be effective if it includes a service orientation toward early intervention for BPD, clinical case management, treatment of co-occurring functional, physical and mental health problems, and it's delivered in a friendly, youth-friendly and welcoming environment. And I guess we've come to the conclusion that really we need to apply the Goldilocks principle, not too intensive, but not dismissive of people's needs. And importantly, our first aim should be not to harm people. And it saddens me that we have to say that. So to conclude, HYPE offers an early intervention program for BPD that's scalable across health systems and which can be integrated with early intervention programs across the range of severe mental health problems. For those professionals in the audience, if you want to join us, there's a Global Alliance for Prevention and Early Intervention for BPD that my friend and colleague, Carla Sharp, and I lead. And you're welcome to email Carla to be placed on the mailing list. So thank you very much for your attention, and thanks again to Prevention United for hosting this.
And thanks very much, Andrew, for that wonderful presentation and comprehensive overview, but also, look, for the great work that you personally have been doing for quite a while now, but also to Orygen, which I think, is obviously you know, creating some great leadership in this space, both in terms of the services that are available, but also the research that's being done there. So congratulations on that, and thank you for your wonderful presentation. It's now my very great pleasure to introduce our next speaker, and our next speaker, and by the way, there's plenty of questions already starting to come into the Q&A, and look, keep them coming. We will come to that section after all the guest speakers have had a chance to do their presentation. So, as I said, it's my great pleasure to be able to introduce Natasha Swingler. Natasha is a young person with lived experience of complex mental illness. She works in social justice and systems change, whilst also studying law and psychological science. She's a member of the Victorian Youth Congress, a member of Orygen's platform team, and a volunteer peer worker who is passionate about the inclusion and prioritisation of lived experience in all aspects of mental health and mental illness. And Natasha is going to reflect on her own and young people's experience. So I might get you to switch on your camera and unmute Natasha, and Andrew, I might get you to switch off, and we'll leave it to you, Natasha. Thank you.
Thank you, Stephen. And I'd also like to say a massive thank you to the BPD Foundation and Prevention United for giving this opportunity for the webinar today. So can everyone see those slides okay?
You're just in the presenter mode. You might just need to switch so that we don't see your forthcoming slide. That's it, perfect.
Perfect, thank you. So my name is Natasha, and I'll be providing my own lived experience perspective on borderline personality disorder. Just to clarify, all views expressed are purely my own and do not speak to the lived experience of anyone else or those living with borderline personality disorder. So a little bit of background, who am I? I'm Tash, I use she, her pronouns. I'm 21 years old. I'm a lived experience advocate, a current accessor of the public adult mental health system in Victoria. Previously have been through Orygen in both the HYPE clinic and the early psychosis clinic. I currently work in hospitality. I'm an associate with YLab, which is social change, Victorian Youth Congress, and have been involved with the National Youth Disability Summit from last week. I've experienced across a number of diagnoses. A fellow advocate said not too long ago diagnosed with the alphabet, which is something I very much relate to. So to start off, why? Why do we listen to young people? No one knows the experiences that we live better than we do. Whilst research may show you X, Y, and Z, or it might give you some concrete findings, and that's great, that doesn't show you everything about our lives. No one understands our lives as well as we do. No one lives the life we do. Listening to us not only helps you to help us, but it helps us to help ourselves as well. When I speak about that, I think it's quite important to point out that listening to understand is very different than listening to respond. Young people's lives, and realistically everyone's life, is incredibly complex and changing. So to understand us and our experiences, you need to listen to understand. And otherwise you may be limited in what you can achieve when working with us and how collaboratively we can work together. Often there are so many things happening for a young person in their life that taking the time to listen and understand us means our working relationship is much more likely to be effective for yourself and for ourselves. Not to mention, listening to us is just the right thing to do. That's how you work with someone. That's how you collaborate. So when we talk about those kind of things, it would be amiss of me not to talk about the agency and choice of a young person. The narrative surrounding diagnosis of any sort really does need to change. I mean, I personally found out about my diagnosis during a research study I was partaking in. The shock wasn't immense. I'd actually thought about the diagnosis for a while previously and wondered whether it did apply to me and what I experienced. But with the stigma attached to BPD, it led to a deep shame and fear. I didn't want to tell others. I didn't want others to somehow guess. When we continually hide diagnoses or don't initiate conversations around them, we continue to portray a level of shame. For myself, this meant Google and the media informed my views of who I was, which was certainly not helpful. I've spent years fighting with clinicians who worked admittedly amazingly with me about the label. And in essence, it really dictated my choices regarding medications, treatments, interventions, not to mention what I thought of myself. Having options for young people, and realistically anyone at all, means that we can cater to diverse experiences and views rather than a tick box system where you fit one service or one team if you're lucky. Many of us already identify that the issues with the current system and its various criterion are there, but it's time for us to go beyond acknowledging or recognizing that fact and rather working towards change, looking for the changes each individual can make and pinpointing our own mistakes. It's about acknowledging we can always do better. When I talk about agency and choice, I'm talking about the options that a young person has and is presented with. It took me years to access therapy and interventions which were genuinely helpful. And these limited options present so many challenges for the different presentations and needs within BPD. Discussion of diagnosis being missing was incredibly challenging. It dictated what I thought of myself. It dictated what I thought was possible for me in my future. And it dictated most aspects of my life, whether that was work, social interaction, so on. BPD, I think consistency is really helpful. I mean, changing clinicians often, changing care teams often, it doesn't help the trust. It doesn't help the relationships you build that require trust. I don't come at this thinking that some of these things are entirely avoidable. There will always be some change within services, and that's not inherently a bad thing. But minimizing changes that actually harm the working relationship between a young person and their clinician or care team is quite important. When we give young people choices, they are able to identify what suits them best. It is about taking a bit of a step back and not thinking that we are the experts in each young person because they have a diagnosis that we are an academic expert in. You can't always know. We're not all the same, and there's enough categorization within the system without applying it to what service is available to each person dependent on what box they tick for you. So, working with this holistically, this has been something that has made a massive difference for me. Having stable employment, help with finding education and study that I was passionate about, and finding work that I genuinely cared about. Integrating more so with my family and my friends, prioritizing my friends, spending time with pets, moving more, being creative, finding something that actually held meaning for me that I was passionate about. That incorporated chances to give back, which has become really crucial to maintaining my wellness. Peer support has been a massive part of that for me. The inclusion of every aspect of a young person's life is really crucial to attaining and maintaining wellness. Without each aspect of the above, there was really no way for me to experience a life worth living personally. Whilst I've always been relatively high functioning, this doesn't mean that things were easy and that I didn't need support for all of those areas. Sometimes it means that we forget perception and reality as separate things. In essence, to me, that meant needing a clinician who wasn't distracted by the multitude of things I was doing each day across a number of different areas, work, uni, VCE, so on, but was rather able to sit with me in the mess of busyness and try to understand why I needed to be constantly busy. I had a clinician once spend an hour with me, writing on a whiteboard everything I'd done that week that had required time, including the basics such as eating, sleeping, showering, as well as the work, study, all of those things. We worked together to try and figure out where I could reduce some of my output in hours so that I could fit in things that made me smile without needing to feel a sense of accomplishment, such as friends, my pets, things I actually cared about, I tell you, this is an example of things that have helped me find perspective and clarity among my own mess, and also the need to prioritize myself as a whole rather than an accumulation of experiences, achievements, or potentials. So, what's worked for me? Well, GBT's been my godsend. That wasn't something I was initially able to access. It took me a number of years. Finding the right clinician, that also took quite a while. But that paired with DBT has meant a massive change in where I am now and what I see for my future. Finding things I cared about and am passionate about has meant I feel better. I can value myself because I see myself doing something worthwhile. That's not always going to work for every person, but for me, that's been super important. Stable employment has been incredible. Obviously, with Australia, there's a lot of restrictions on who can access what in regards to Centrelink and supports like that. Employment, working in hospitality, it's not been the best thing I've ever done in my life, but the stability and the routine that provides has been incredibly helpful. I do avoid too much free time as well. Supportive and inclusive spaces, that's been my friends. Friends with their own lived experience who have been by my side every step of the way. We talk about peer work, but in essence, that's informal peer work. Having friends that really, really understand what you're going through, don't judge you based on those things. It's invaluable. Working in the lived experience space and systems change and advocacy as well has been quite crucial to where I'm at now. Without working in these spaces, I wonder whether or not I would feel like I'm making a difference. And for me, that's been crucial. To be able to put one foot in front of the other and say, I didn't change the world today, but I might have had an impact on one person's experience. Someone didn't have to go through what I had to go through today. So I acknowledge that there are therapies that work more so for some than others and vice versa. For me, I actually fought coming into the GBT space. I'd spent so long with the BPD diagnosis, challenging it, running from it, refusing to accept it. To then have GBT offered as a therapy was a challenge. After all, in my own brain, it was really synonymous with BPD. Whilst I now know that GBT wasn't created with BPD in mind, rather a number of symptoms of BPD, such as chronic suicidality and self-harm, this coloured my view of it from the outset. Good old self-stigma. I didn't deserve to access something that was going to help me, let alone if it came with a label. I was incredibly lucky to access a clinician in the public mental health service that I'm with who specialised in DBT. She took the time to understand my context and the dynamics that played into every aspect of my life in a way no one had before. Without this, I don't know if I would have been able to engage with DBT, but by pure luck this time, my engagement was quite different, and I was willing to work and push for some change. Over the course of about 8 months, I learnt the basics of DBT in a one-on-one setting with this clinician, which is not the way DBT is actually typically intended to be delivered. We started with distress tolerance, and oh boy, that was a real big game changer. I went from engaging in self-harm behaviours most days to an occasional slip-up every now and then. The confidence I had in my own ability to manage day-to-day increased, and I began to utilise skills from across DBT without even recognising it sometimes. I completely and wholeheartedly admit that there are particular skills such as radical acceptance that really do continue to elude me, but I feel equipped in a new and fascinating way to push forward and to fight for a life that I really do want. So there's been a few shout outs today so far to Marley Jewel, but this one is definitely another shout out for Marley. So this is a DBT art group I've been involved in for the last 6 or 7 weeks. It's peer led by Marley, who is trained in the psychiatric survival model of IPS, DBT skills and group facilitation, is an ACA accredited counsellor and a provisionally registered Masters of Art Therapy. So this group involves DBT skills, but incorporating art and other creative mechanisms into how we utilise DBT skills. It's involved real life examples of how these skills and art apply to my own recovery and discussions about how and why things work for some people and don't for others. To be able to hear from someone who's lived these experiences, how she has incorporated things into her life that have made such a difference, has been truly incredible. When we talk about peer support, we're also talking about the power imbalances typically present within the medicalised model of mental health care. That's incredibly minimised within peer work, and particularly within this group. Relatability and connection are crucial, but I think the big thing for me has been the hope to see someone else that is actually living a really good life and has made the most of everything that they can. So it's been an amazing chance for me to consolidate and refresh the DBT skills I've learned over the last year, and it's been incredibly refreshing to have them delivered by someone with lived experience who can share their own utilization of these skills, their own experiences with mistakes and getting back on the DBT bandwagon, let alone hope and recovery and art. Personally, I've actually quite struggled with the creativity aspect. It's the first thing to kind of go out the window for me personally when I'm a bit too busy or just not doing as well. It's also something I find challenging because things rarely turn out the way I'd like them to, which can trigger some pretty intense emotional responses. But the environment provided in this group, the content of the group and the other wonderful participants, it's often the highlight of my week. Personally, I've had very limited access to formal peer support, but there's no denying the power for motivation, hope and recovery that it's inspired for me personally. So what didn't work for me? That's a bit of a list. Cognitive analytical therapy, whilst interesting, didn't seem to provide any further insight for myself personally. As with most other purely talking therapies, I didn't find much difference. I'm quite critical in the way I think, and I already analysed my own thought process. Medications weren't the solution I hoped they'd be. The changes to my care team certainly didn't help me build trust or work even harder to better where I was at, and conflict in my home and work environments really exacerbated my distress and minimised my ability to tolerate the distress. This is by no means to comment on the skills or abilities of any individual clinician. I do recognise that everyone is busy, constrained by the limitations of the systems they work within. However, when I talk about purely talking therapies not working for me, I only ever realised that after a very basic counselling class at university. We'd spoken about how talking therapies don't work for people who overthink or overanalyze their own thought patterns. Not weeks earlier had I been talking to a friend about how there was only so much use for me in talking things through with a clinician, as in my head, I'd had that conversation 7 times and I'd gone down the road even further than I could with a clinician. I had initially thought that maybe I just wasn't trying hard enough, wasn't being open enough, or was simply just a hopeless case. I was wrong, and I know that now, but I didn't then. Medications have been a part of my life for a long time now, and whilst certainly they have had their uses, and certainly they are helpful for some people, I had practically no response to most medications. And I often question whether that meant somehow I was faking everything, whether I was putting it on. No one ever seemed to address that medications don't work for everyone, and in fact that they don't work for a lot of people. So where do I think we can create change? Now, I'm sorry, I am going to have to go back to presenter view because I am missing some notes and I need my notes. So whilst peer work has certainly seen an uptake in Australia, it is still behind the true potential that it holds integration of peer work in every aspect of care and treatment has so much potential. I've spoken briefly about the access I've had to peer work and the impacts that it's had on my own recovery and the hope that I hold for my future. But I do often wonder about what early intervention with peer work would have meant for my own experiences and the way I perceived myself. I believe integration of peer work would have had a significant impact on the self-stigma I've experienced, and the chance to speak with someone who truly got it might have shifted those perceptions early on, let alone instilled a very different image of what my future could hold. We talk about prioritizing lived experience voice a lot, but this needs to be driven by those of us with lived experience, as realistically, we can tell you what we need and what was missing more than someone else. Education and training being provided by those with lived experience is key to this. Co-delivering training has been incredible for my own development, for my own insight, and gaining an understanding of why and how some things happened the way they did. It's also changed and helped me comprehend where I can make the most change to these systems that treat us. And it's helped me in working with other young people to explain those parts of the system that seem so inadequate or unfair. So currently I'm working on the Hospitals in the Home initiative in Victoria. I'm quite hopeful that this system of providing intensive services and supports to young people whilst they remain in their communities will be a much better experience for young people than patient admissions. I'm admittedly yet to delve too far into a lot of these changes, but I'd like to flag that here as a potential game changer for young people to develop skills to manage their distress and crisis in a more relevant environment. But it's important to note, I really do hope to see that this workforce, the hospital and the homes, will actually be representative of the communities it serves. Finally, what would early intervention have meant for myself? In year 12, I lost so much time. I'd been struggling with low mood, fatigue, and substance abuse from the age of 9 or 10, but my first contact only came in year 12. As an academic scholarship student at a high-performing school, the pressures I was putting on myself meant an escalation in my risk to the point where I was actively suicidal. After making an attempt on my own life, I was admitted to the emergency department and sent home to my terrified parents. Not too long after, I'd be readmitted for a 2-month period. This pattern continued for quite a while as my mental health deteriorated further, and the impact on my year 12 and my BCE was profound. Whilst I had friends studying hard and enjoying their social lives, getting their license and cars, looking at university options and so on, my sole focus was flipping between engaging in self-destruction and trying to just plod through. I wish I had the chance to engage in year 12 in that final year of schooling and those memories that I could look back upon fondly, but I don't. It was some of the most challenging moments of my life, and there is no way for me to get that back. Early intervention, education, and understanding of the supports available to me almost a decade earlier, as I began to deteriorate, may have meant all of this was minimized. My parents may not have spent years sleeping on the wooden floor next to my bed, trying to ensure I didn't take my own life or experience complications related to substance abuse. I may not bear the physical complications of the things I did to myself over the decade. May have actually thought I was a decent person, worthy of love and support. Whilst now I absolutely look back at my experiences and am proud of how far I've come and hopeful for what my future may hold, that doesn't mean I would wish these experiences on anybody. Early intervention has the potential to stop and even minimize not only my own suffering, but the suffering of those around me. So I'm going to leave you all with a quote from the beloved Marshall Lynham. The way I describe the situation is that Mother saw me as a tulip and I desperately wanted to make me into a rose. She thought I'd be happier as a rose, but I did not have what it took to be a rose. Not then and not now. This tulip-rose conflict eventually became part of the way I talk to my clients in DBT. This is what I tell them. If you're a tulip, don't try to be a rose. Go find a tulip garden. All of my clients are tulips and they're trying to be roses. It doesn't work. They drive themselves crazy trying. I recognise that some people don't have the skills to plant the garden they need, but everybody can learn how to garden. Thank you.
Thank you so much, Natasha. That was just amazing and really insightful. I mean, the Q&As, people are saying, I'll read one out. Thank you, Natasha, for your articulate insight in what BPD has been like for you. So, you know, we're all listening intently. Look, that was such a wonderful, honest and powerful presentation, Natasha. Really, really appreciate that. Thank you. And look, just to reassure people that we are, you know, collating the questions and answer that you are putting in the Q&A, and we'll be coming to those very, very soon. So thanks, and keep putting those questions there. But and now it gives me even great pleasure again to introduce the last of our guest speakers today, and that's Susan Preece. Who's a family peer support worker at Orygen Youth Health, and so has a lived experience of being a carer. Family peer support offers support to all family members, friends and carers of young people, both in the inpatient unit and the community clinics. Susan has been involved with the Making Sense of BPD sessions designed for families of young people at Orygen, including being part of the peer moderator of a moderated online social therapy, the MOST program that Andrew mentioned, called Kindred, which supports families of young people with BPD. She believes passionately in hope and recovery in mental health. So I'll just, without further ado, throw over to Susan. So thanks, Susan.
Hi, everyone. It's great to be here this afternoon, and particularly the privilege of following Natasha's presentation. It was fantastic to hear her, very raw and honest presentation. I hope mine will be similar in some ways. It was interesting she mentioned hospital in the home too, because in that team going out to homes will be a youth peer support worker and also a family peer support worker, so that we're hoping to have all the wraparound services for young people to keep them out of hospital and support them where they are in their homes. So I just wanted to talk today a little bit about how carers and families feel. I mainly work with families in the Hype Clinic at Orygen, which Andrew's referred to. And I think it's important for I want to just explain the language, because the word carer is used a lot, but a lot of people don't like it. But it's a good generic term, because there's so many different people that are involved in the support and love and care of someone who is experiencing BPD. And I think mostly, and we, from the poll we did today of the carers that are with us today in the webinar, 62% of those that are caring for young people under 26. So it is mostly that age group, and they're the age group that I would be encountering their families. So it's mainly families. So I'll jump around between family and the word carer as well. But of course, it's really the support person that the young person chooses to be with them. So that could be a flatmate, a friend, a partner. But in my experiences, I've mainly worked with families, members and partners, and also most primary carers in BPD are a mother. So they're the main group that I do work with. I'd like to also acknowledge the courage and bravery of people who have BPD that are with us today, and also those who care for them and love them. There's a lot of courage on both sides sometimes, and also like to acknowledge those that may have lost their lives as well. A lot of care families come to us, and they are often sometimes burnt out because they've been trying to seek support for their young person for quite some time, and they haven't been able to slot into the right sort of care. and being bounced around from GPs to all sorts of other health professionals. So sometimes the families are very bruised by the experience with a healthcare setting. And sometimes I think it's important to remember that if families aren't wanting to be engaging or engaged, that sometimes it's not because they're not interested, it's because they're feeling quite isolated. So if you are a clinician here today, I'd encourage you to keep massaging the relationship with the family, friends or support people, because everyone values people that support them. And if we can get the conversation going between everyone, it's really important. We know that a lot of the concerning issues for carers and families are around the impulsivity, the risky behaviour, and some people who are in trouble with the law as well. And that can often be very frightening for families. I know in my case, a lot of loss of sleep, high blood pressure, different things that happened to me physically as well as emotionally because I loved someone who was unwell. And I think that this is an issue, particularly when it involves self-harm and suicidality. So I think if we can try and hold those families and support people, sometimes it might only be one or two people that the young person wants involved in their care. It might be none, but it often is just a few. And if we can try and support those people, and even if a young person says, I don't want anyone involved in my therapy treatment, then it's a question that needs to be revisited, because relationships change and some people change their views as they go on, particularly in treatment. So I think it's important to acknowledge that the massaging of the relationship with the people around the young person is very important. I think the mood swings sometimes of BPD and some of the outbursts that people will have in relationships can lead to a bit of a roller coaster existence. Sometimes the turmoil of relationships means that carers and families are unsure what to expect, they're unsure of what to do, and they feel, and this is a constant refrain, that they feel like they're walking on eggshells. They're not quite sure what to say or what to do to be the most helpful, and they haven't had any support in that. So I think it's very helpful to try and hear them and hear their concerns as well. And often only after one first session with a family member, usually a mother that I see, you can see their shoulders drop and their relaxation when they're heard, when someone has heard their frustration, and then they're more open to hearing the next step along what might happen in the process of the person they love being treated and how they're going to be involved in that. So I'd encourage you to not judge people by their first presentation, but that families can be really helpful, and they can be really flexible, and they can relearn how to do things. I have to say that in my case, it's taken a heck of a long time for me to relearn some patterns that I have in relating to people, but it does take practice. And coming from a teaching and training background, I really believe that we can re-look at how we relate and communicate to people. Carers often feel worried, they feel fearful, and often they're frightened of not knowing or not understanding. So, for example, why would my daughter want to harm herself? Like, who wants to do that? That would be something that a mother would think. So it's very confronting for a mother or a father, or particularly parents, where protection is parenting 101. Keeping my loved ones safe is my job. And I've been doing that and giving advice to that young person all their lives about how to do that. And all of a sudden I'm out of control because I can't feel that anyone's listening, and that I can't protect this person I love from harming themselves, or thinking about harming themselves, or even just being confused and distressed. So families can also feel isolated, and this is quite well documented about carers feeling not only stigma about what BPD might be, but also self-stigma about what people might think. For example, if they hear that some people with BPD have had a very abusive background, or that the families have been not as good parents as they would hope, sometimes they feel, I wonder if people think that about us as a family, even if they believe there's nothing that's happened. It's certainly how I felt when a clinician told me about childhood abuse and how that can be a pattern sometimes leading up to people being unwell. So I think it's important that we understand that carers and families can be feeling a lot of maybe shame and embarrassment just because of what society thinks about BPD. I also think that it's very taxing sometimes on families if the young person lives at home, and most of our clients at Orygen do live at home. It's very taxing being the emotional I call it the emotional traffic cop of the family. So organising other siblings or partners, or trying to manage the emotional relationships in the family. And often parents in particular feel that they need to control that situation so that no one's unhappy, and trying to keep a lid on all the emotions that are going on. And so I think it's really important to acknowledge that a family could come to you really exhausted with that having happened to them. Sometimes a diagnosis is a relief for families that I've met. So hearing that someone has BPD after, as I said, being bounced around from different clinicians and different therapies, that they feel that at last we've got a label for this, and others don't want it, as I said before, because of some sort of stigma or self-stigma. So it can be different for different people, and that's something to explore with families as well. One of the challenging things about dealing with young people, and we deal with young people about 15 to 25, but particularly the very younger group, is that what's the difference between BPD or emerging BPD and adolescent behaviour, risk-taking? And I think that's often a question that comes up across all mental health issues around with families about, well, you know, is this just, you know, a normal adolescent behaviour, or is it what we should be starting to worry about? So self-harm or risk, drug use, alcohol use, things like that. So one of the things that families have told me is that trying to be the friend, if you're a parent in particular, being the friend of your child with BPD doesn't always work. That sometimes there are situations where you need to be the parent, and for the sake of the whole household or the whole family, there do need to be some things put in place so that everyone can live get on with their own lives, basically. So also I think you also can't choose your kids' friends is something that parents often wish they could, but sometimes young people can get into company where there is risky behaviour going on, and that can be very troublesome. And some families want to control that, and you can't. So it's about sort of, well, what are the best things we can do in this situation? And talking to the clinician, of course, most importantly, talking to the young person about their lifestyle choices and how you can be supportive to them and with them in that. There's also some guilt and grief in around it. Sometimes if there's been family breakdown, family trauma, some parents, particularly if they're the remaining parent caring for someone, they can feel really guilty about that and ashamed. And that can be something that they might need to work on over time. Some people said they've sought counselling around that guilt and grief, and maybe the idea of, I guess, the idea when people think about, have hopes and dreams for their children and their loved ones, say a partner too, who they come together on some sort of footing, and then all of a sudden things change. BPD comes into the picture and things are different. So how to actually work through that change and accommodate that change as best people can. And also the concept of being the good enough parent and not the perfect parent. Excuse me. That often you can't and you shouldn't control everything, and how to be the good enough person in the relationship and not get everything right. And lots of parents, particularly mums, think that they should have the perfect family. And it's interesting how often they think that there's lots of perfect families out there and our family is the only one that's struggling. And that's just not the case at all, as I found in my own life. It's also not selfish to self-care, and that goes for everyone, and as well as people who love and support someone with BPD. It's okay to step back, to listen, to not have the answers. It's okay to feel lost. It's okay to feel incompetent. It's okay to just to be silent, and that then gives the young person who might have BPD a concept of them being competent and them being able to make those decisions themselves. So sometimes silence is golden, and from my point of view, I've always wanted to be the fix-it person and make everyone in the family happy. And in the end, everyone does have their own journey to work out, and families are sometimes need to step back. It's really hard if someone is suicidal and you feel a strong sense of protection and safety. I've met families who sleep outside their child's room or in their child's room, listening for them breathing each night because they're so anxious that they might take their own life, even just for a short period of time if they're left alone. And it's very hard but important to walk alongside families so that they can start to let go of that and to somehow know how to keep everyone in the family safe, but realise that they can't completely be in control of all of that. What are some things for strategies for self-care? Well, I think Natasha's already mentioned peer support, and that's important too for carers and families. Spectrum and Mind have support groups that get together, and often some people suggest that peer support is more helpful than counselling in this situation. So hearing other people's stories and realising you're not alone and that everyone's might be struggling with certain things is a really powerful support. Counselling might be helpful for families, particularly if there's grief and loss issues involved, but I would really suss out a counsellor or psychologist carefully about, first of all, whether they understand carer issues, but also if they understand BPD issues. And I do my research on that and just not go with the first psychologist that the GP gives you, but actually try and drill down into to find a person who really understands who has done some work in the area that you need. Online BPD support groups for carers can be helpful, but you have to be wise who you tap into because some of them can be very stressful and overwhelming, especially if they're global. So I think it's important to be careful of those groups, but some of them might be really helpful. The BPD Foundation, having a look on their website for different things, as well as the SANE forums, which are moderated and therefore are more controlled and safer. Respite is really hard to get. So some of the people I work with, the carers that I work with, are solo parents. Getting someone to come and support someone who's quite unwell can be tricky. And so often it just doesn't work, and nor does the family member want to leave their loved one anyway. So I think respite, if there is any, needs to be a little bit more creative. And I'd suggest that, you talk with the treating team around that as well. Because I come from a training and teacher background, I guess I'm very fond of the concept of training families and carers in skills that they can use. And that's not to make them sort of robotic in the way that they communicate, but just even things like, you know, you don't have to talk all this time, you don't have to have the answers, or I like, you know, the concept of that if maybe you're in an argument with someone in the home, you go out of the home with your phone and you call someone who you have trained to speak words of sense to you, to speak comfort to you in that situation. And also someone has told me where they've actually trained the cat team of their loved one to talk to them as the carer and de-escalate their emotions as well. So I think that's a really helpful thing, that you can have someone to support you if you don't have someone in the home to support you as well. That you can find someone outside as a lifeline to chat with and to feel that they understand you and they're comforting you. I also think that doing some sort of skills training in caring for people who have suicidal thoughts can be really helpful. And because some carers have never encountered suicide before, or live with someone who might be self-harming. So some training in that area, and there's more and more coming online. We could do online training as well now. And I think, you know, I just totally recommend where Natasha put a list of who can work with you as a whole person. Nearly all of those people also apply to carers and families. So yeah, that was a terrific list. Thank you, Natasha. I think the chronic suicidality, it can be a real problem for some families, that the fear of that. And I think coming to terms with that you can't save the situation all the time, and being able to know where to step in and where to step out, and having some sort of mentoring and support around that. Finally, just if you're a clinician, I just want today, if you're here, I just wanted to mention some of the things that carers and families find helpful. Families don't like being locked out completely. And so I think if the young person doesn't want carers involved, then trying to engage some people in the team who can also support the families. People like me who can support the family, but I don't treat the young person. And then talking to the young person about, well, you know, do you think it's time we chatted with your mum and dad? Or do you think it's time that we talk to someone that you want to be involved in your treatment team? Modelling healthy language and strategies really is great was great for me with a case manager who would actually model how to communicate in a friendly way with my son, but in a way that was really helpful and didn't sound too health professional like. So helping families to get that language. You model it, and you can also help them and talk them through it as well. I think teaching, a lot of people just don't know how to do reflective listening. They've never done it. And how to remain curious about the young person and how they're feeling, how to step back and just listen. These are all skills people can learn. And keep encouraging the carers to balance risk with the development of competence. So trying to always allow that space for the person they care for to be, to make the competent decision themselves, to run their own lives, to make choices that are healthy. And I think just always remember that you see the young person once a week, probably at most, but the carers and the loved ones often are doing the 24/7 care. And so they do deserve some support around that as well. So thank you for today.
Thank you very much, Susan, and to all our speakers today. That was wonderful. And look, you know, the questions and in the chat, everyone's agreeing. You know, thank you so much, Susan. Very insightful. Thank you for sharing and feedback also again on Natasha's presentation, and everyone being very grateful as we are. So I wonder if I could just ask everyone to unmute and bring their cameras back on. Look, we probably don't have a lot of time, and but there's plenty of questions here, and so I might turn to them. And so, Natasha, there's a question for you in the Q&A. It's, hi, I'm wanting to ask Natasha if you could please expand on your thoughts regarding psychological therapy being unhelpful for overthinkers. What could a psychologist take from this observation to develop their practice with individuals?
Thanks, Stephen, and thanks to whoever's asked that question. Personally, what I needed was structure. Okay, I'm going down kind of, oh geez, sorry, quoting someone here, Holly, train to Trigger Town, then this is what I do. There is this and this and this that I can draw on. For me, that meant being busy, trying to distract myself and finding something that worked so that I wasn't going down that kind of overthinking path. I don't think that that's something that you can necessarily stop, but being aware and identifying that and working with me to identify the things that do help, rather than sitting there and talking it through when I've already talked it through 7 million times in my own head. Behavioural. For me, it was behavioural, finding things that I could actually do differently.
Thanks, Natasha. Look, this is a question about the service system out there. So I'll just ask it, and I might throw to someone. Previously was in Victoria and tried to access support through Orygen and Spectrum for my daughter, but also my family. As we lived in regional Victoria, we were out of zone for Orygen. Has this changed or at all, or are young people and families outside Metro Melbourne able to access specialist services for BPD now in Victoria? Andrew, I might ask you to answer that first and then over to Rita as well.
Sorry, I just had some technical problems, but I think it was the one about, were you asking about the accessing services outside of the region?
Yeah, so who's eligible for Orygen and where else can people go for specialist services for BPD in Victoria?
Yeah, so this question really, thank you to the person asking it, because this question really raises a fundamental issue with the mental health system, that some of the problems that we face are not unique to BPD. They're shared problems of everybody seeking help in the system. And Orygen is limited to the west of Melbourne, to everything kind of west of Sydney Road and down to Werribee and out to Sunbury and Sunshine. But of course, that's only covers about a quarter of the population of Melbourne. And one of the challenges is that there is no systematic access to care for people with BPD, and various services have various degrees of welcome for this problem. Headspace is a good option for people trying to access care, but again, people will tell you that often they're left on waiting lists and find it difficult to access care from those services. The other services that are available, Rita will probably talk about Spectrum. But, you know, I think fundamentally there is not a system of accessible care, and particularly for people in rural and regional areas where it's a lottery as to what services you get.
Yeah, and Rita, do you have anything to add on that?
I guess I largely concur with what Andrew is saying. Another limitation as far as Spectrum is concerned, that it's funded as an area mental health for adult mental health, which is the ages of 16 to 64. So therefore there are some limitations on young people being able to access services via Spectrum. It is a statewide service. So there's limitations with probably travelling to Melbourne. However, Spectrum is started at what's termed a personality disorder initiative, and that's having a specialised clinician currently in 6 area mental health services that receive supervision and support from spectrum clinicians. So it's hoping to actually make spectrum type services more accessible in people's local communities.
Yeah, that's great. Thanks, Rita. So the next, this is both a comment, I think, and a question, so I'll just read it out. Peer support is amazing, but highly disregarded in Australia. We need those empowered to use their platforms to advocate for funding and structures to be put in place to elevate peer mentors to the level of respect they deserve. This means funding training, full-time positions that are paid adequately. The idea of volunteer peer workers needs to end. We don't ask psychiatrists and psychologists to work for free because they wouldn't. So peer support must also be allowed to work outside of the medicalised model. Psychiatric trauma in BPD is huge, and we need to start providing treatment outside of those medicalised systems of care. I might throw to Susan first and then Natasha. What do you think?
Thank you. Yes, well, huge fan of peer support, obviously. The Royal Commission was also very fond of concept of peer support, and we're seeing more money flowing in to services for it. I agree, though, the EFTs are way too small to get that continuity and to build the workforce as it should be. It's an emerging workforce, and like many workforces that are emerging, it still lacks a lot of in some ways, discipline, good pay, good backup by the organisation. Role clarity is a big issue still about what they can and can't do as peer workers. I could go on forever, but I won't. And what I'll just say is that Orygen has just done some videos that are around peer work for both youth peer work and family peer work, and uploaded them on their website. So I'd encourage anyone interested in the workforce to really look at those, because I do the family one, and I've outlined all the issues there. So thank you for the question, because it's really an emerging, exciting area.
Thanks, Susan. And Natasha?
Yeah, I wholeheartedly agree with Susan. Peer work has been really instrumental in myself coming to the state I'm in now, which is very much better than where it's been previously. I think peer work has been incredible, not only to be involved in, but to receive it and to see the difference it's made for myself with so many other young people. Accessibility-wise, it's just not there yet for Victoria, whilst we have, particularly with Orygen, a number of peer workers for post-discharge and working on the inpatient unit and in the family carer space. There's certainly not enough, and that needs to change. There needs to be a much higher value placed on peer work.
Thanks. Andrew, next couple of questions to you. I'll give you both. They're similar but different. So, hi Andrew, could you address why Orygen doesn't offer DBT for young people and why they use CAT rather than DBT? And there's also a question around over the 15 years that you've been running the service, what has changed? What would you say, is different about your approaches nowadays than it used to be?
Yeah, thank you to both of those questions. I guess I might address the second one first, because it might help answer the first question. Over the years, one of the things that we've discovered is that individual psychotherapy is not actually the kind of core of how we can best respond for people with BPD. It's a preference of some people, and certainly we offer it, but actually much of the effective ingredients, and our research over, 20 years now has told us this, much of the effectiveness of services is actually around the kind of model of care and the kind of diversity of components of the program. And so individual psychotherapy is one component that suits some people, but many people get considerable benefit from care that doesn't always include individual psychotherapy. The other reason that we chose, the reason that we chose CAT originally was when we started, the evidence base was very, very small. And CAT provided a practical model that could actually inform all aspects of care rather than just the individual therapy. But it also, so it can be delivered as an individual therapy, but it's also a model for thinking about how you work with people. And so and also from a very practical point of view, DBT, which was around at the time, has very, very limited capacity to see the numbers of people that are required. It's a long and intensive program, and there's nothing wrong with DBT. And you've heard Tash talk about how good it's been for her. But I guess it's about a hierarchy of interventions and thinking about what's helpful at large scale and at what point do you introduce more intensive interventions and also more expensive interventions into a healthcare system. And we need to try and match people with the right treatment at the right time. So DBT certainly has its place. I guess I would kind of liken it a little bit to, I don't know, renal transplant units or coronary care units or something like that, that it's a very intensive, expensive part of the system, and it's needed for some, but it's not always needed for everybody. Many people make fantastic progress with very different interventions. You also heard Tash talk about art therapy as an important component of her recovery journey. And then finally, the other issue with DBT is there's a lot of claims made about the evidence supporting different therapies, but actually no one therapy is superior to any other. There's never been any study to show that. I liken them all to, I guess, like washing powders. They all get your clothes clean, but they make different claims on the box. And so they're all very valuable. And I think that I'm not trying to suggest that any particular kind of therapy is not valuable, but the ones that are based on a model of BPD that involve collaboration are all kind of equal in terms of their effectiveness.
Thanks, Andrew. That's wonderful. Look, I'm very conscious of the time and that we're already about 8 minutes over, and there's still quite a few questions. Just in terms of some practicalities, people are asking about the presentations, etc. So we are recording this webinar, and we will make it available through, or Rita will make it available through the Borderline PBD Foundation website, and we'll see whether Orygen can do the same. People are asking whether people are comfortable with sharing their slide presentations. Look, we'll talk about that, and if so, we'll make those available alongside the recording as well. So just to let people know. And so, look, I guess I might just ask one last question, and I'll throw this to Rita, and then other people can join in. It was one of the early questions, so I feel bad not asking this one. It was one of the first. So how can workplaces work with someone with BPD whose behaviour impacts negatively on other employees? So that was their question. How can an employee be supported without being required to compromise or accommodate? Rita, what do you think of that? Someone who's asking, I guess, from a non-BPD perspective, how people at work can be supportive.
To be honest, I don't know if I'm the best person to answer that question, but I would see it as very much trying to come to a position of mutual understanding. It's not an us and them situation. So supporting the staff to develop an understanding of why they may be seeing those sorts of behaviours would actually be my way of approaching it. And it's not a case of necessarily giving in to somebody, it's just a case of developing an understanding so you can work with that.
Yeah, great. Natasha, what would you say to that question?
Spot on what Rita said. Work with me. That's it. That's all I ask. If I am causing an issue, if there is something I'm not aware of, come to me, have a respectful discussion. I can't change something if I do not recognise that it is an issue.
Thanks, Tash. And Susan?
Ditto to both of those, nothing to add.
Yep, fantastic. All right. Well, look, we've already gone 10 minutes over. Look, I think it's been just a tremendous session and, you know, some incredible personal insights. And I think, you know, from the Q&A and the chat, you know, everyone's been incredibly appreciative. So on behalf of the audience, I would like to thank you all, Tash, Rita, Susan and Andrew, for this fantastic presentation. As we said, we will be making the recording available through the BPD Foundation website. Look, it's just been great having you all, and we really at Prevention United appreciate the opportunity to work with Orygen and BPD Foundation to host this particular webinar during BPD Awareness Week. And look, it's just been a great learning experience for us as well. So really appreciate the insights that everyone has provided. So on behalf of us all, thank you all to our guest speakers, and we wish you all the best and have a good week. Thank you.
Thank you. And I'd also like to take the opportunity, Stephen, to acknowledge the support of Prevention United in helping us with running 3 Zoom sessions. It's been fantastic having your support. So
Yeah.
thank you.
Thank you. And actually, before I go, and you've just jogged my memory, there's an evaluation form. So when I end this webinar, if you could please just stay at your computer, there's just a couple of questions for our evaluation that we'd really appreciate you answering. So look, on behalf of us all, thank you for your attention. It's been wonderful. Thank you. Bye-bye.
Thank you.